Hello, and welcome to part one of our webcast, Metabolic Matters, MASLD in Obesity, Early Detection and Management. I'm your moderator, Rachel Deere. Please note, a portion of this webcast was recorded at ObesityWeek in Atlanta, Georgia on November 4th, 2025. And here are our faculty: Dr. Jamie Almondoz, Medical Director of the Weight Wellness Program and Professor of Medicine in the Division of Endocrinology at UT Southwestern, and Dr. Lee Kaplan, Director of the Obesity and Metabolism Institute in Boston and Professor of Medicine at the Geisel School of Medicine at Dartmouth. Here are our faculty disclosures. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals. All activity content and materials have been developed solely by the planning committee members and faculty presenters. And here are our learning objectives. Analyze the natural history and clinical consequences of MASLD to differentiate disease stages and describe outcomes, and evaluate and apply two evidence-based strategies to improve the detection of MASLD, MASH, and hepatic fibrosis. I will now turn it over to our faculty.
So we're going to start off today by talking about MASLD. And until recently, I think so many people thought that this is a very niche condition. But when you look at a global prevalence map like this, what you can see is really an epidemic hiding in plain sight, where 1 in 3 adults in the US are living with MASLD, almost half of adults throughout Latin America. But interestingly, when you look towards Asia and you see prevalence rates of around 30 or higher, what we see in these populations where the prevalence of obesity is lower is that MASLD is really tied to metabolic health and not just to imperfect markers like BMI. And that's why I think it's so important for us to contextualize this as a cardiometabolic condition. When we look broadly at the disease of MASLD, again, with shared pathophysiologic pathways that lead to ectopic fat deposition, inflammation, cell injury, we can see that there are shared common pathways through the spectrum of cardiometabolic impacted organs, including the heart, the pancreas, and the kidney, outside of the liver, and increased risk of cancers, not just hepatocellular carcinoma that people think about, but higher risks of cancer outside of the liver too. So what we see is that there is really an interplay of cardiometabolic health where the liver is at the crossroads, and it's important for us to acknowledge that this is a systemic disease and not something that's isolated to the liver alone. What is MASLD? I feel like we started a little bit ahead, and so we're going to take a few steps back when we look at definitions. So there needs to be liver steatosis, which is 5% or greater liver fat, in addition to one or more trait of the metabolic syndrome. We're all pretty familiar with metabolic syndrome criteria, so there is a weight or BMI or waist circumference related criterion. There's elevated glucose, either with a diagnosis of diabetes, elevated fasting glucose or A1C, hypertension, elevated triglycerides, and also low HDL depending on which sex we're talking about. And so this is the context of the metabolic associated steatotic liver disease. So it's not steatosis in isolation, but also a metabolic factor. MASLD is one part of a spectrum of steatotic liver diseases, formerly known as fatty liver disease, where we see MASLD and then MASH or steatohepatitis. Typically, when we think of steatotic liver disease, many will think of alcohol. And so there's, of course, the alcohol-associated liver disease component. But this is the real world, and many people consume alcohol, and there's going to be a spectrum of consumption of alcohol and a spectrum of what's now called MetALD, where there's a metabolic-associated steatotic liver component with an alcohol component. And we can say whether it's MASH predominant or alcohol predominant, depending on self-reported consumption, or there can be more objective measures, such as phosphatidylethanol levels or other ways in which you can measure alcohol consumption in your patients. In addition, there are some other rarer causes of steatotic liver disease, including drug-induced liver injury, monogenic diseases, and of course, cryptogenic steatotic liver disease when we're just not sure what causes it. When we look at contributing factors for steatotic liver disease, there are several. There are things that we can ingest, such as high fructose ingestion, saturated and trans fats, alcohol, and certain drugs and toxins can all increase the risk of steatotic liver disease. Certain phenotypes, including increased adiposity, central or visceral adiposity, and insulin resistance type syndromes, including type 2 diabetes, but also metabolic complications like primary hypothyroidism. In addition, there are genetic factors such as PNPLA3 or epigenetic factors in microbiome and inflammation that can also predispose people to MASLD, in addition to prior viral infection. Interestingly, female sex and estrogens can be protective against this, but it makes for a complex story and patient journey across the life course as these change. When we think of progression of MASLD through the stages, this is kind of a typical diagram that you'll see where it goes from healthy liver to isolated steatosis, so just liver fat. But then there's cell injury and inflammation, which leads to MASH and then fibrosis or scarring within the liver, which can eventually transition to hepatic decompensation. And so you can have cirrhosis that's compensated, cirrhosis that's compensated with portal hypertension, or decompensated cirrhosis. We often think of hepatocellular carcinoma, or HCC, as a complication of MASH and cirrhosis, but it's important to note that this is not kind of a branch point or an end point from terminal cirrhosis. This is something that can occur at any point along the pathway and should be screened for in this high-risk population. When we try to classify the stages of fibrosis, we can have no fibrosis, so that's MASH with no fibrosis, F0, mild fibrosis, F2, which is significant, F3, advanced, and F4, which is cirrhosis. And so you'll see in a lot of clinical trials and other data and clinical staging that there are different F classifications, and that's important, and we'll go into that in more detail as to what this means, because there's a terminology at-risk MASH, which is typically F2 and beyond, where people are at risk for adverse liver outcomes. But how long does it take for this to happen? So for those who have F1, so kind of early fibrosis, about 3 decades. For F2, maybe 2 decades. And for F3, about 5 years or so. And so you can see that fibrosis is one of the strongest kind of predictors or a significant factor in looking at the timeline with regards to progression to cirrhosis. But just to make you paranoid, 1 in 5 people can progress more rapidly than that and can develop cirrhosis within 5 years. So it's important for us to make sure that people are being assessed regularly as part of this. And that's really important because of the volume of people who have MASLD. When we look currently, it's 1 in 3 adults in the US, and it's estimated to be 40% by 2050. And while that may not sound, well, that's not a huge jump, that's 120 million adults with MASLD. And when we look at MASH and people who are at risk, that's going to top 20 million by 2035. And so the prevalence of MASH is going to be almost 10% by then. So it's important for us to be aware of this because it's a significant driver of healthcare cost, utilization, and also mortality. When we look, there are certain groups that are at risk, so who to pay more attention to in clinical practice and research studies, those that are 65 or greater. When we stratify outcomes by age and mortality is what's demonstrated here in the left-hand figure, but also by race ethnicity. There are certain groups, and here it's non-Hispanic, white, and Hispanic groups that have higher rates of mortality when adjusted for age. And I think this is kind of a concept which is new for many times when I talk in primary care audiences, that people who are living with MASLD and MASH are much more likely to die of a cardiovascular complication than they are to have an adverse liver event that leads to mortality. But also more so, extrahepatic cancers more so. And I think it's important for us to contextualize what does comprehensive patient-centered care need to look like as we're looking at a disease with such a high prevalence. And I think one of the key take-homes from this should be that cardiovascular disease is the leading cause of death for people who are living with MASH, and we need to make sure that we're not just focused in on the liver, but cardiometabolic health and wellness in general for this population. And when we look at kind of shared pathways for lipid accumulation, inflammation, and fibrosis between what's going on in the liver and what's happened with atherosclerotic disease, it's easy to contextualize, or easier to contextualize, why there's such a relationship between this when there's shared pathophysiology and drivers for people developing cardiovascular complications when they also have liver complications. So we need to think about this much more comprehensively. And it's also important for us to work out how far along are they with regards to fibrosis. What this image shows is that fibrosis stage is a very strong predictor, particularly F4, for hepatic decompensation here in this figure, and then also all-cause mortality, not just liver-related death. And so it's important for us, once we identify that somebody has MASLD, do they have MASH, and if so, where are they along that spectrum, and to iteratively follow them, because if we're not, we may miss people who are progressing more quickly than others. So this is chronic disease management at play. And I just want to kind of highlight that, MASLD is really an under-recognized and under-diagnosed epidemic. And it's important because patients won't often report symptoms of abdominal pain or discomfort, or their transaminases may not be elevated. And many of my clinician colleagues will say, well, if the LFTs are fine, then why worry? It's 1 in 3 people and more than 70% of our patients who have obesity. And so it's important for us as members of the Obesity Society and people who treat obesity to be aware of the high prevalence of steatotic liver disease, but also that 1 in 3 are living with MASH. And we've just talked about how this can increase risk of diabetes and cardiovascular complications, and also important for us to make sure that we're doing patient-centered, comprehensive care where the liver is really at the crossroads of cardiometabolic health, and it's not an isolated problem within the liver. So with that, thank you so much for your attention. I'll hand it over to Dr. Kaplan.
Thank you, Jamie. And what we're going to do for the next part of this discussion is we're going to talk about a patient. And as Jamie has said, it's a long process. So rather than starting with a patient who comes to you today with just steatosis, and then we'll sit here for the next 30 years while we're waiting for the patient to progress, we're going to do it the opposite way. We're going to have a patient who presents now, and we're going to look back at that patient's history and see where different interventions today might be used compared to the ones that might have been used in real life for this patient 20 or 30 years ago. So this is a 46-year-old woman who has been pregnant twice, given birth twice, with class 2 obesity, a BMI of almost 38. She's referred to us in the obesity space, us in the liver space, wherever, even in primary care, if we are a specialist within our primary care practice around metabolic disease, for evaluation and treatment of the obesity. That's why she's coming to us. The obesity is complicated by prediabetes, dyslipidemia, gallstones, and MASLD. She was initially noted to have mildly abnormal liver enzymes back in 2007 when she was 28 years old. You can see her elevated AST and ALT are slightly elevated, normal alkaline phosphatase, normal bilirubin. Platelets were 190,000 at the time. She had no evidence of viral hepatitis, and her abdominal ultrasonogram revealed mild steatosis and no evidence of gallstones. She had a BMI at the time of 29.5, hemoglobin A1C of 5.3%, consistent with her current prediabetes. She at the time was officially without diabetes or prediabetes. She reported social alcohol intake of about 5 drinks per week. If this patient presented to you today without a known diagnosis of MASLD, so we know she has MASLD, but she presented the way she presented in 2007, what would be your next step in the diagnosis or management of her liver disease? So 41% will calculate a FIB-4 score, and then the remainder is split evenly amongst 3 other choices: obtaining an abdominal ultrasound, arranged for liver elastography or FibroScan, arranged for Oh, that went down a little bit, and then treat the obesity empirically with semaglutide, knowing it's effective for treating obesity. Okay, so I want to just discuss this, and if anybody has questions, we're going to give 1 or 2 minutes with each one of these questions. There are only going to be 3 or 4 questions about the case, but back in the day that she was seen in 2007, we didn't really have a strategy for addressing MASLD or MASH. Of course, it was called NAFLD and NASH at the time. But today, we would say that in any environment, what we really want to know about more than anything else is to what degree this patient is likely to have progression of their fibrosis. And so when we talk about the FIB-4 score, it's named for fibrosis. It's because that's really what we most want to know to stratify the risk that this patient is presented with. And so we would calculate today a FIB-4 score, because a FIB-4 score is something that's easy. It is in the electronic health record of almost all the new electronic health records. If you don't happen to have that, or if you're in a practice that doesn't use an electronic health record broadly, all you have to do is go to Google and get it. It's all over Google. And so let's if I could go forward here and talk a little bit about how we do this evaluation and screening. So I'm going to talk about who we evaluate, what the clinical markers of the severity of fibrosis, which is our goal to assess, what the non-invasive estimation of fibrosis severity is beyond clinical biomarkers, and then when do you refer to a hepatologist or other specialist. In 2007, we probably would have referred everybody to a hepatologist. And in full disclosure, I am a hepatologist, but I'm putting my hat on as an obesity medicine physician for today. And so back then, we would have probably sent everybody that we were concerned about to a hepatologist. But if we think about what's going on in the obesity world that you're all familiar with, we're taking care of about 5% of people with obesity these days. And as we start to take care of 10, 20, 30, 40%, we're going to discover a huge reservoir of undiagnosed and unappreciated MASLD and MASH. And we're basically going to overwhelm the hepatology community, just as we would overwhelm the obesity medicine community if the primary care community didn't take care of much or most of the obesity in the world as we get to those larger numbers. Maybe we can get away with it today, but we won't be able to get away with it tomorrow. So we're going to talk about sort of how it looks moving forward rather than looking backward. Who should be screened? Anybody with diabetes, anybody with obesity, as Jamie said, with an additional suggestion of metabolic disease. I don't think you have to have the metabolic syndrome, but just a component of the metabolic syndrome. Basically, evidence that you have more. Some people would argue obesity and prediabetes would be sufficient. But people with metabolic disorders without obesity, because a small but significant portion of MASH is not associated with obesity. It's estimated to be in the range of about between 5 and 15%. Incidental finding of hepatic steatosis by imaging and elevated transaminases if you find them. I want to emphasize these last two, because these last two are ones that you might find in a patient, but we're not going to go look for as a primary screening tool, and I'll come back to that in just a second. So how not to screen for MASH? Liver enzymes alone are not a way to screen for MASH. 40 to 60% of people with every stage of MASLD, whether it be steatosis or MASH or cirrhosis or beyond, do not have elevated transaminases. So therefore, it is a reason to screen, but it in and of itself is not a sufficient screen. Ultrasound. Lots of people want to get ultrasounds. You'll see a nice bright white liver with an ultrasound, but it doesn't really teach you anything. It's too non-specific. It's not quantitative, and to know that somebody has fat in the liver doesn't tell you anything about the inflammation, the cell injury, or the fibrosis. And as we've already talked about, fibrosis is the one thing we really want to understand if we want to stratify the risk that this patient. And so we don't recommend anymore in the liver community to get an ultrasound. Now, many patients will get ultrasounds for other reasons. Gallstone disease, they'll get ultrasounds for other abdominal things. Pregnant women may get an ultrasound. And so it may be discovered that they have fat in the liver. But that's only serendipity. Just like you may see that somebody has elevated transaminases, and that should be a reason to go look for MASH, but it is not a way for you to go find MASH. You'll go find MASH through these other diseases that the patient has. And assessing the degree of fibrosis, again, I want to reemphasize, is essential. So the FIB-4 consists of the AST and the ALT as part of it. The patient's age is critical, and the platelet count. So what are they suggesting? Well, this is a disease that takes time to develop, so the patient's age is a predictive factor. The platelet count is a predictive factor because as patients progress along the fibrotic scale, or the fibrotic pathway, at some point they start to get mild portal hypertension, which is associated with a drop in platelet count. And so that becomes a very significant contributor to the overall FIB-4 score. And then, of course, AST in the numerator and ALT in the denominator, because AST is more of an indicator of acute inflammation. And so what you do is so you're basically taking the AST and dividing it by the square root of the ALT. You don't need to know any of that, because the FIB-4 calculator will do all of it for you. So don't try to figure that out. This is not a board exam preparation course. This is just to know that these are the components that have been shown to be predictive. Now, there will be newer predictive scores in the near future, and in other parts of the world, ELF and others are being used, though I don't want to give short shrift to them. But for today, the recommendation for us in obesity care for primary care providers is to use FIB-4 first. So how do we interpret the FIB-4? We interpret the FIB-4 by 3 levels. If the patient has a FIB-4 score of less than 1.3, we would argue to repeat the test in 2 years. Don't do anything further, because that patient is at low risk for fibrosis. Slowly progressive disease, we want to see it in 2 years to find out if they're a rapid progressor, or if for whatever reason we caught a bad day or bad day for prediction. If the patient has a FIB-4 score of greater than 2.67, and so the two numbers to remember are 1.3 or 2.7, or 1.3 and 2.67. If it's greater than 2.67, then we consider that patient at high risk. And we would either, if you feel comfortable treating MASH, and one of the answers to the previous question was that you might treat MASH yourself without further ado, then go ahead. Or if you're not as comfortable, this is an indication to refer to hepatology, and they'll go further. If you're in between, we don't say it's intermediate, we say it's indeterminate risk, because there's quite a bit of variability. This is not a perfect test. And so we would then move on to elastography, which is to measure liver stiffness, which is really pretty much a measure of the combination of fat in the liver, which increases stiffness a little bit, and fibrosis, which increases stiffness a lot. And so that would be the next test that you would do. I want to stop here for a second in case anybody has any burning questions that they want to know the answer to. Yes, sir. Good question. Very good question. Because age is in the numerator, we usually use increase above the age of 65 to 2 instead of 1.3, because the age alone will cause it's the age times the AST divided by the platelet count divided by the square root. So you're absolutely right. The age, because of age keeps going up, no matter what's happening in your life, every year it's going up, much to many of our chagrin. So yes, the cutoff generally, but in general, we're not seeing these patients very, very frequently above the age of 65. So if you were to remember one thing, I'd still want people to remember 1.3. We can always adjust. And of course, in between, it could be from 1.3 to 2, you can imagine you get close when you're in your 50s as well. Okay. So I've already said that. So let's continue with the patient. So this patient, we saw her when she was 28. Remember, she's now 46. She had 2 children at the age of 32 and 35 years, respectively. Her pregnancies were associated with substantial weight gain. She gained 33 pounds in the first pregnancy, 39 pounds in the second pregnancy, and each pregnancy was complicated by gestational diabetes that was first treated with glyburide. That was in 2010 or 2011, but between 2011 and 2014 or 15, whenever she had the second pregnancy, the rules changed because glyburide was recognized to be problematic for progressive disease, and so she was treated with metformin and insulin during the second pregnancy. Today, we worry about insulin causing progressive disease. So if she were pregnant today, I just want to mention parenthetically, we would try to use one of the newer agents for treating the diabetes rather than. But you can see she just happens to have gone through at times when the rules were changing, when the guidelines were changing. So she was treated, though she did require therapy for her gestational diabetes. 8 years ago, she was 38 at the time, she had an episode of acute cholecystitis. Her AST was 51 at the time. Her ALT was 45. Her alkaline phosphatase was elevated. As you can see, her bilirubin was close to normal. Her platelet count was normal at 210,000. She did have an ultrasound because she had cholecystitis or evidence of cholecystitis. She had gallstones, hepatic steatosis. She had a laparoscopic cholecystectomy. And because she had a cholecystectomy, she had an intraoperative needle biopsy of the liver because of the ultrasound showing Steatotic Liver Disease. And that biopsy revealed that she had a NAS score of 5. The NAS score goes from 0 to 8, and it includes steatosis, assessment of steatosis, inflammation, hepatic cell injury primarily, and so those 3 pieces of the score add up. It can go from 0 to 8. She has 5, so she has an intermediate level of MASH. She had mild fibrosis, F1. So this is a good place for me to start by emphasizing that was then, and today, we typically do not use liver biopsy as a guide because we have much better tools. So I want to emphasize, and as you teach, some of you may be primary care providers, others of you are obesity medicine specialists, and others, and I want to emphasize that patients need to know, and the primary care community needs to know, that we've moved away from liver biopsy finally, and so that is not the expected place to go. She had a liver biopsy, the surgeons were there. Even today, I think we would not see a biopsy even though the surgeons were there. So I think that I just want to tell you we're looking back at her history. So we have a second question for you. Now, this is, if this patient at this stage, so don't put yourself back at the time of when she had these events, but if she had the same story and she presented to you today, what would be your next step in her diagnosis or management of her liver disease specifically? Recommend that she stop all alcohol intake and repeat the test in 3 months, obtain an abdominal ultrasound to assess for biliary obstruction, calculate the FIB-4 score to assess the risk of fibrosis, arrange for a liver elastography to estimate the degree of fibrosis, treat the MASH empirically as we're talking about before, but in this case with resmetirom, because that could be available today, and treat the MASH and the obesity together empirically with semaglutide. So the plurality of you wanted to treat the MASH and obesity empirically with semaglutide. Second was arrange for elastography. Third was calculate a FIB-4 score, but that was only 20%, and then the others were less commonly done. Jamie, what would any comments you want to make on what we should do at this point?
I think a lot of it depends on kind of the circumstance in which the patient is presenting. You know, if people were coming to the weight wellness program at UT Southwestern, weight is their primary focus, and so as you kind of do a comprehensive evaluation of your patient and you have shared decision-making around we're treating obesity and the complications, including the MASH, I think it's a no-brainer for my clinical practice. I think for those in primary care, where they're looking at other things and patients are presenting with different expectations, I think it's important to meet them where they're at and to educate with regards to kind of what the risks are. It's a politician's answer. I'd probably treat.
You're a good politician, though, so it's I mean, based on that answer. So what we want to do in this situation is this patient, I want to go back to the clinical scenario. This patient is presenting to us having just had cholecystitis. And so for those of you who said you want to do a FIB-4, that would have been appropriate in the first instance, but the patient has cholecystitis, has elevated LFTs because of the cholecystitis. And so the FIB-4 is no longer reliable because there's an acute event that affects the liver and the liver test. So we can't use the FIB-4. As Jamie said, of course, you might want to move forward to treat the MASH, and there's nothing wrong with treating the MASH with semaglutide because you've got a reason to do it. You know how to use the drug, and it's very effective. It's as effective as resmetirom, certainly for the key outcomes that Jamie talked about, which we'll talk about a little bit more, but is the improvement in fibrosis and the improvement in the inflammation and the liver injury. However, I would say that we'd like to know the degree of fibrosis for the same reasons we've been talking about the whole time. So in order to do that, my preference would be to do the elastography so we get a sense of what's going on. That doesn't stop you from empirically using the treatment or starting treatment if you feel comfortable doing that. It would be reasonable if the elastography is suggestive that the fibrosis is getting pretty severe to then refer to a hepatologist at that point. So let's see what what we're talking about here. So vibration-controlled transient elastography, or VCTE, is the generic name for what many people call FibroScan because FibroScan sells the most product. They sell about 90+% of all the devices that do this in the United States. And it measures liver stiffness to estimate, not measure the severity of fibrosis. So in terms of interpreting that, again, it's typically people whose FIB-4 score would be between 1.3 and 2.67 that you would go to the next step. But in this case, you're going to that step because you can't trust the FIB-4 score because the FIB-4 score is going to be skewed by the fact that the patient had acute cholecystitis. So the interpretation is we look at liver stiffness, which is measured in kilopascals, and less than 8 and greater than 12 is what you would have to pay attention to in terms of the numbers. So if you remember anything, less than 8 and greater than 12. Less than 8, low risk, repeat in 2 years. You're back to repeating in 2 years. Greater than 12, you either want to treat, and if you want to treat, somebody in obesity medicine is probably going to use semaglutide, but there's nothing wrong with using resmetirom. It's almost equally effective with respect to fibrosis and inflammation, but it, of course, doesn't cause weight loss. Know that in between, once again, you have an intermediate response. This is not a measure of fibrosis. This is a marker of fibrosis. And so you don't know, and it can be wrong. I mean, but it doesn't hurt to treat the MASH because you have evidence of progression. Whether that's F1 progression or F2 progression or F3 progression, we wouldn't know. But what we can say is that it would be quite appropriate to do that. I should also mention, it's not shown on this slide, that above 19 is considered very strong evidence of cirrhosis. So if you're getting significantly above 12, probably you're going to want to move more toward a referral to hepatology, because at that end of the spectrum, right now, we don't know the degree to which cirrhosis can be reversed. There is evidence that it can be partially reversed, but it's early evidence, and so we don't know that. And so getting a hepatologist involved, if we're talking about significantly above 12, is probably a good idea, even if you feel comfortable treating the MASH itself. So that gets above that.
Hi, I'm a pediatrician and I see elevated LFTs left and right and steatosis of the liver. Is the FIB4 validated for pediatric use or reliable?
Yeah, less so because of the age issue. It'd be very difficult for a pediatric patient to get into a FIB4, so no, I would not use FIB4 for that. ELF is a possibility, it's not always available. All the components of ELF are not available to you, or you can go straight, in that situation, go straight to VCTE.
Okay, thank you.
Yes, sir.
So the FibroScan is a screening test for fibrosis, and you already have a biopsy that tells you how much fibrosis. What does it add to do a FibroScan after you've already had your biopsy?
I'm glad you asked the question because I forgot to say what it adds. It adds a baseline because you're not going to do another liver biopsy. If this patient presented today, first of all, they presented today having had the liver biopsy, you're not going to follow that forward. So what you want is you want to know the non-invasive test so that you can follow it. That's exactly a very good question. Thank you. Yes, ma'am.
Elastography is only accurate up to a certain BMI, is that correct? And would you recommend doing a different test over a BMI of 37, or what cutoffs do you use?
Yeah, so if for higher BMI that you can get stiffness as a result of the extra fat, and so that's what you're referring to, and that is true. Many people are arguing to go to ELF directly in that situation, and I think it's a little bit controversial. None of the societies have a standard for how to deal with that yet in terms of, and it's being discussed and debated, but there is no. What I'm showing you here are the standards and the algorithms that have been approved and written and approved by the ACE, the American Diabetes Association, the MASLD, the Liver Society, and the American Gastroenterological Association. But there are no such things for people whose BMI is that high.
So I do a lot of FIB4 tests, NASH, FibroSure tests, and I frequently see diabetic patients, weight loss patients, screening, If I'm seeing constantly F2, F3, or indeterminate or high FIB4, and I proceed to elastography, and elastography does not show that F0, F1, my question arises from the fact that although I'm interested to treat that, and I'm tempted to, but what would be the validity, sensitivity, and specificity of FIB4 and NASH FibroSure that we use for screening, but ultimately leads us to the elastography, which 7 to 8 out of 10 times are not showing the cutoff where we can start treatment? And my second question to that is that if that is true, and if scientifically so, then why not all the high-risk patients that we all think as providers, clinicians, go right to the elastography?
The main reason that we don't go to elastography is the availability. Elastography is very spottily available around the country. I think many of us would say that if elastography were as broadly available as, say, DEXA is for bone disease, then we would go straight to it, as you're suggesting. That said, the DEXA for obesity is not widely available, which is an irony because the DEXA is in the building, but it's not used by the obesity community, or it's not available adequately for the obesity community. So I think so a lot of that is very practical. If you've got it, I can tell you in our center where I practice, we basically go almost straight to elastography because we have elastography. There's nothing wrong with doing that. And if, by the way, the FIB4 is elevated, and then you go to elastography trumps FIB4. And if the elastography is below 8, then you just wait 2 years and do it all over again. So at that point, you would bypass the FIB4 anyway because that's the way you're doing it. Yes, sir.
This may be a controversial analogy, but I would look at FIB4 almost like a BMI, where what we have is something that's a screening tool that can help us to identify at-risk people. Unfortunately, it's more common than I'd like, where there's discordance between one testing and then the elastography, and you're trying to work out what next. In our center, what we would then do is move on to MR elastography or referral to a hepatologist for adjudication to work out what's next. And I think as more and more people are now being screened, I think it's important to acknowledge that there are a lot of limitations to FIB4, but it's something many of us have access to in terms of our patient registries or as part of our note templates that we can develop, which can help us to be aware of the prevalence of steatotic disease in a way that we haven't been paying attention to it. Thank you.
Yep. I think we'll probably see a change in all of this over the next 5 years just because of advance of the technology.
What you just watched was recorded live at Obesity Week 2025. Before we close part one, I want to reinforce a few key takeaways. MASH is far more prevalent than many clinicians appreciate, and it remains significantly underdiagnosed amongst people living with obesity and type 2 diabetes. As we discussed, MASH reflects ongoing hepatic inflammation and cell injury, which accelerates fibrosis progression if left unrecognized. It's also essential to remember that the leading cause of death in people with MASH is cardiovascular disease and not liver failure. This highlights that MASH is truly a multi-system disease with implications well beyond the liver. FIB4 is an incredibly practical screening tool. It's simple, inexpensive, and widely available, and it allows us to identify patients who may require further evaluation with elastography or referral to hepatology. And finally, about 20% of people with MASH will experience rapid progression to cirrhosis within 5 years. Early identification of these individuals is critical so that we can intervene while the disease is still modifiable. This concludes part one of the program. In part two, we'll take a deeper look at emerging therapeutic targets, including multi-agonist incretin therapies and liver-directed agents, and how these may reshape future treatment pathways for MASH. With that, I'll hand it back to Rachel.
Thank you for watching, and please complete the evaluation as your thoughts and comments help us develop future education. Thank you, and please be sure to check out part 2 of this webcast series. See you next time.